Hey, chiropractors, welcome to Modern Chiropractic Mastery with your host, Dr. Kevin Christie, where we discuss the latest in marketing, business, and professional growth with some of the leading experts in the industry. Hey, docs, welcome to a little bonus episode. This is the first of our MPI MCM Mini-Series in January of 2023. There'll be 4 episodes on being world-class at treating athletes. And it doesn't necessarily mean you have to be treating professional athletes. It could be being world-class in your town, working with junior athletes or high school, college, or even professional. And so we dive into 4 main topics. And today we're talking with Dr. Mark King of MPI on multimodal approach to treating athletes. And we dive into some various topics as well. But these 30 to 40-minute episodes will be coming out on Mondays in addition to our regular Thursday episodes, so a little bit extra for you this month. And if it goes well, which I suspect it will, we might do a few of these each year with different clinical aspects and other clinical entities to provide you with some even more content to sharpen the saw clinically. And so we dive into a very important topic today and a few various ones that I really liked with Dr. King, and it was great. We are excited to have the MPI Sports Symposium come back. It's something that's been on the shelf for a few years for cancellations due to COVID, unfortunately, but we're excited to have it back. And this year it's going to be in Kansas City, which will be great. It'll be in Overland Park, Kansas, to be exact. And it's going to be everything on the spine. And this is March 25th and 26th. I'll actually be there myself as well. I'm going to be speaking with the reps and past reps on Friday, but I'll be hanging out for the weekend. And this sports summit's going to be on the lumbar spine. And it'll have Mark King, Corey Campbell, Jason Ulm, Brett Winchester, Rich Ulm, David Seaman. And so it's a great lineup to talk all things sports injuries related to the spine. Every year they alternate the region. But yeah, I'll be there. I'm excited to do that. You can check that out at motionpalpation.org and just check out their seminars tab and sign up for that. It's a great one. I was there at the last live one, which used to be in Chicago, and just a ton of information. And so if you're looking to improve clinically, and especially in sports injuries, I'm hoping these 4 episodes help you, and I'm also highly recommending the Sports Summit. So check that out at motionpalpation.org. All right, here's my interview with Dr. Mark King of MPI. All right, I got Mark King here on the episode. This is the first of our little MPI MCM mini-series, and we're going to dive into clinical with the theme of being world-class at treating athletes. And like I've kind of promoted a little bit on previous podcasts for this is, being world-class at treating athletes doesn't mean you have to be at the pro level and, being on a pro team. Sometimes treating junior athletes is harder than treating pro athletes, but it's being world-class in your community for the athletes that you are training of all levels. And today we're going to talk about the multimodal approach of treating athletes. And so welcome to the show, Doc. How are you?
Doing fantastic. We're really happy to be here.
Yeah. So this is something that we wanted to dive into, and let's lay the groundwork a little bit for our audience here. When you say, I know most of them will know, but I never want to assume, when you say the multimodal approach to treating athletes, obviously you would have a multimodal approach to treating anybody, but as it relates to what we're talking about, what does that mean exactly?
Well, at MPI, we obviously have a focus on our palpate and adjust skills, but we are fully aware that that as your only tool is not enough, especially with the high level athletes. Can be, so part of what we do is we want to get really good at palpate and adjust, and then we want to be able to integrate these other tools in with our treatment protocol. So the multimodal approach really just speaks to this ability to integrate these other treatment modalities in with your palpate and adjust foundation. When you're treating athletes, if you're good at palpating and adjusting, that goes a long way. Whatever level, like you mentioned, it can be anything. For me, athletes can be pros to Olympics to high school. It can be the weekend athlete. I treat a lot of amateur athletes, weekend warriors. We, as per typical in a chiropractic office. So, it can treat a wide range of them, but they are going to typically need more than just an adjustment. An adjustment.
Yeah, and I want to touch on that a little bit because people will find themselves in unique scenarios where they'll be treating athletes in private practice, and obviously the multimodal approach is going to be very necessary in that scenario. And then there might be the great opportunity you have with the high school team or the college team or the pro team where they could be bringing you in for just one thing, right? That could happen. So you got to understand what modalities, what you are bringing to the table, and get very clear on that ahead of time, because it could be where you're brought in to do. We know a lot of active release technique providers, and I know you've done some collaborations with ART, and obviously there's a fair amount of NFL teams that would bring on an ART provider.
Sure.
And that particular doctor might be doing soft tissue and manipulation. So they're using two things out of their tool bag in that scenario. Whereas in their private practice, they're doing rehab, they're doing dry needling, maybe they're doing all these different things. And so you got to get clear on that for sure. And so sometimes you're not going to be able to apply all your tools in the certain settings, but in private practice, it's obviously going to be very important.
Yeah, so if you're working for like if you're working for a professional team, for example, they may have a track that they want you very specifically to stay in, like you're mentioning, and sometimes like some of the guys say they want the chiropractor to come in and do palpate and adjust and nothing else. If you want to work with that team, that's what they want. That's what they think they need. And you may say, well, I know more about whatever rehab, or I'm better at ART than anybody that's else on their healthcare team on such and such a sports team. So what? If that's not what they ask you to do what they ask you to do, and then maybe you can expand that as you go along. As you mentioned, Kevin, in your private practice, you can use the tools you find most effective. But understand, you mentioned ART. Lots of professional athletes benefit by getting ART or other soft tissue techniques, but ART is the most popular one. And the really good ART guys and gals, some teams, that's all they want out of those practitioners. Mm-hmm. Some of them are doing palpate and adjust with ART. It varies. Every team seems to be a little different, because I talk to these different guys around the country that work with these different college and pro teams, and they, each team seems a little bit different. So, like I say, if you want to be part of that team, you have to work within the parameters that they lay down until you're the one in charge. And then, and then if they want you to do these other things, you need those other tools to be more comprehensive in your treatment approach to athletes.
Yeah, and I think what's cool about the multimodal approach as well, and we're going to touch on it in private practice, but then it gives you opportunities. Like I know for me professionally, I was brought in to work WrestleMania one year, and it was strictly to do ART, and that was all I was allowed to do. That's all they wanted me to do. I wasn't allowed to do manipulation, and so that was what I was brought on. I've been on situations where it's purely palpation and manipulation, and that's great. I've been on situations where I ran the entire SFMA FMS for an NFL combine training program down here, and that was a big part of it, and that was in our wheelhouse. So it also, having the unique skill sets and all those different skill sets could lend you to certain opportunities that you wouldn't have gotten before. You just have to do a good audit of what they're expecting and make sure you apply that.
Yeah, and if you just think about being part of their healthcare team and wanting to be part of that to help the athletes, you have to find that you have to find that common ground. Like what I'm trying to say is, like, maybe you say, well, I'm perfectly happy doing palpate and adjust. And some of you are going to say, well, that's just not enough. If that's all they want me to do, then I don't want to be part of it. Okay, well, that's fair. Then don't. You just have to, like I say, it's not normally for the pro teams and the college team. It's normally an athletic trainer who's in charge of dictating where people go and what they do. And so you may not agree with them. So that you have to decide if that's a deal breaker for you or not. So like you said, at that WrestleMania, they only wanted you to do ART. Well, then I would, if I was in that situation, I'd do ART and roll. And then the next time they may say, hey, can you do these other things? So yeah, that's a trick. It can be a tricky, sticky situation. You just have to decide if it's okay for you, what based on what they're asking you to do.
Yeah, and it can be frustrating because you got this, you could do these things in your private practice and you can't there. But let's bring it back into our private practice. And that's where we're going to spend most of our time today
Okay.
on this episode. And um, you know, you mentioned different populations, junior athletes, pro athletes. There's also the aging athlete, right? Like I'm
Mhm.
down in Boca Raton, Florida, and we got a lot of 75-year-olds playing pickleball, tennis, golf
Sure.
every day of the week. And we deal with a lot of active aging population in sports injuries, which is cool. But do you put you on the spot here a little bit? You got potentially the 18-year-old coming in, the 12-year-old, the 70-year-old, the weekend warrior. Does anything change in your approach of those different populations of athletes as far as how you're evaluating them, or some of the input you're taking in, or some of your treatment methods? What would you say to that based on the actual different types of populations?
So a lot of times you end up being the primary care provider. The is what a role I am often in. So I may be in with a 15-year-old high school gymnast or high school basketball player, whatever, and they come in with back pain, let's say. Well, in the back of my mind, I'm always a little worried about a lumbar stress fracture with a spondylo. So I always have to be the one kind of trying to figure that out if they're not responding to conservative care. The elderly, I may be dealing with somebody that's trying to figure out, hey, I like to run or I like to play pickleball or whatever, but my hip or my knee for my shoulder, whatever, is a train wreck. And what do I do about? Am I ultimately going to be able to? Am I ultimately going to have a replacement, a joint replacement? I'm trying to say. So I end up being a traffic cop a little bit on some of these people because I don't do the joint replacement, obviously, but I know who. I'm in Cincinnati, Ohio. I know who the good ones are in Cincinnati, Ohio, and who I would send my family to, or who I would have do it on me. So the elderly, I might have to play traffic cop and get them to a surgeon, or I might be able to do the treatment myself and keep them going. The 12-year-old or 20-year-old, I may need to, I may be able to handle everything, or I may need to get further diagnostic testing, X-ray, MRI, whatever, CT, whatever the case may be. So it's a combination of being a manual care provider and being a traffic cop, essentially a primary care physician from the musculoskeletal standpoint.
And that's one thing I wanted to, that's a great point because I've gotten to know you and your practice over the years. And I would say one of the things that I know you do, and I know your practice in general, I don't know all the doctors, but I know in general, you have a very good network of physicians and other, healthcare providers that you refer out to. And it's like you've developed a really good network around that. Is that something that you strategically did? I know you've been there for a bit, but do you feel like it's of utmost importance? And I kind of have my opinions on it, but to be world class, in my opinion, of treating and evaluating athletes is like you need to have a great network of other providers. What are some of your thoughts on that? And what did you do to build that?
Yeah, I early on went and observed some surgeries, and I followed some other docs, orthopedists, neurosurgeons, PM&R guy in their office to see what they're doing. I did the same thing with some other chiropractors, but I started developing that network early on because I wanted to know who to send these people to. I saw a guy earlier today who had a knee replacement a couple of months ago, and he went to the guy. He was about to go to a guy in Cincinnati who I would not send my patients to ever, and I didn't badmouth the doctor. I
Mhm.
just said, yeah, you don't want to go there. You want to go over here to this other guy. And he ended up going to the guy I recommended, and he had a good result. And, those knee replacements are a big deal any way you slice it, but he had a good result. And I just know the other guy he was thinking about going to, it just, too often it doesn't go well. So I just didn't want him to see this other guy. So one of the things we do in our practice is do MD letters to the referring physician or primary care physician, their family doc, And Chiro Up has an unbelievable system on their MD letters. It's so good, it's ridiculous. But and I don't work for Chiro Up. I'm just making the point that they do a great job. But we had done it long before we discovered Chiro Up. We did our own. Chiro Up just does it better and makes it easier for you. But we were always doing MD letters, basically. Hey, I saw Mr. Jones. This is what I found, and this is what I'm gonna do. And that develops your network, and they start figuring out that what you're doing makes sense, and that what you have a logical approach to your clinical patient care. So that starts to expand, and you ask people, oh, I saw such and such a whatever podiatrist. Oh, what'd you think of Dr. Smith? Well, he said this, this, and this. So you start learning your way around it. But yes, I think it's a great way to expand your base, because these patients will come to you looking for help, and they will trust your referral.
Yeah, and I one of the things that I did over the years too is, and you mentioned, say, podiatrists, that was always a tricky one because you get ones that just clip toenails on 80-year-olds, and then you get other ones that are foot ankle trauma specialists
Yes,
who are great
very
with
skilled.
biomechanics and like gait
Yes,
analysis. And so I started to whittle down, okay, am I dealing with referring out someone with a sports injury? I've got a podiatrist that's like, I call him a foot ankle specialist. And,
yes,
and I would trust him with any sports injury. And, sometimes they don't keep up with the rehab protocols. Like they'll still want to brace someone for 8 weeks instead of maybe a little more aggressive rehab on an ankle, a grade 2 ankle sprain on an
right.
athlete. And so I want to know those things about physical therapists that I might refer to, or podiatrists, or acupuncturists, or orthopedists. And I think it gets really important um, when you're building out that network to make sure. And to your point, you didn't want to badmouth the doctor, um, which is great. And I don't think anybody needs to do that. You can always just say, oh, like, based on your goals and your scenario, I think this doctor would be a little bit
Right.
better of a fit, right? So you're not like bashing anybody, and you're making it kind of tailored to that person, that patient. And they say, "Oh, that makes sense," and so you'll kind of steer them away from that other person.
Yeah, and they want to know, they typically don't know that this other guy they were going to go to is a is a lousy surgeon. They don't really know that. I mean, kind of how would they know that? So yeah, you can be diplomatic about it without being without bashing the people. There's no upside to bashing the guy. As long as you can steer him where you need to go, then just do that and move on. But you
Yep.
need to know who the best people are in your town.
It's a huge help, and being a team player in that, I mean,
Yes,
it's you almost got to recreate in your community what I say a pro team would recreate in the training room, right?
right.
And their whole organization, they're going to have everything, and so you want to do that in your community, build a team, and feel really good about that. Because sometimes being the best doctor for that patient is knowing when to get them out of your office and where to get them to appropriately. And if you fail in that too much, that's an indictment on you if you're not working on that.
And I tell you, those patients, you refer them to the right person, they remember that, and they refer other people back to you. That
Right.
it is actually a practice builder to refer the appropriate patient out to the correct doctor. That actually builds your practice. You
It
say, well, you're not treating them. I know, but I wasn't going to get the right result anyway. And they appreciate that I was honest to say, I'm not the right guy, but here's the right guy. And here's his phone number, and go from there.
Yeah, and I've seen too many chiropractors, and I did this in the past early on where I might have started treating something that I really wasn't comfortable with, and didn't think I was going to get the results, but I was like, yeah, we'll give it a shot anyway. And I wasn't completely transparent with them on that. And I think if you're transparent with them and you say, you know what, like, I think we need to co-manage this, or something like that, they'll appreciate that. But yeah,
Yeah,
I
you
agree.
can simply explain to them that, hey, I think you may need to be need another procedure, a surgery or whatever. We can help you get prepared for that with what we can do with our manual care and our rehab. And and if you respond quickly, then maybe we can delay that surgery or avoid that surgery. But you can get the ball rolling. Like where I'm in Cincinnati, a lot of the people that are the surgeons that I would want to use sometimes it takes a while to get into them, or it takes a while. You got to get the MRI or whatever you're doing beforehand. So I'll kind of get all that stuff rolling, and I can be treating them if I think that there's a legitimate chance that I can help them. But I'm not sure. I can at least start treating them and see how they respond, and then you get the MRI or get the referral over to Dr. whoever and get the evaluation going. So at least the ball is rolling in the right direction.
Yeah, and two things I want to spotlight on that in under this multimodal approach is one, if you're concerned about something, but there's going to be a delay in them seeing the person you're referring to, if you have that multimodal approach, you can cherry pick some of the things you do that you know won't have a contraindication to their condition
Right.
or their injury. So it gives them something and some alleviation. You're being transparent with them that that's not the total picture, but we have 2 weeks before you can get in to see that doctor. So that multimodal approach can be very important in those scenarios. And then I think you got to look at this multimodal approach is sometimes it's the things you do, and sometimes it's the things that are outside your practice that other providers do. And that is a multimodal approach. And sometimes you have to co-manage that.
Right. That's a great way to say it. So one of the things I really emphasize is that you can't be great at all these different things. Like, you're a great palpator and adjuster, but maybe you're not great at nutrition, or, maybe you haven't taken a good soft tissue class or whatever. But, you can work with other people that might be better at that than you. And that's fine. I don't think you're going to be fantastic at every single tool in the toolbox. So you pick the ones you can be great at, and kind of add to that as you go along through your years, but have the help. Like, some guys only want to palpate and adjust. Totally fine. Have somebody that can do rehab, have somebody who can do soft tissue, because your patients palpate and adjust is not the answer beginning and end for every patient, obviously.
Yeah, definitely. And so let's say that athlete comes into your practice. What are some of the things that are on the table for them, pun not intended there,
Right.
that they may get? Obviously, palpate and adjust, we've talked about. I know they get soft tissue. What are some of the other things that you may prescribe for them inside your practice?
Most all of my rehab is DNS based, dynamic neuromuscular stabilization, the Prague school. So that's just my system that I use. I think they're great. I learned a lot from them. I've taken piles of classes and read their books and articles, and I just think they do a great job. And it's a great system for low tech rehab in the office. So we do that. I'm lucky because I have a couple of DPTs in the same building that are part of our practice who do also know some DNS, and they'll incorporate that into part of their rehab program. So I don't want to take the time necessarily to do all the DNS rehab. I might teach them an exercise or two on a given visit, but if they need an hour twice a week for 4 weeks, and then once a week for 4 weeks or something like that, then I have DPTs who will do that, and they're a rehab focused, as opposed to me. I'm a little more manual care focused, is a good way to say it. I mentioned the soft tissue. I do a fair amount of nutrition in my practice, and I call it nutrition light. It's kind of, best way I can say is it's based on the whole deflame model that David Seaman teaches. That's kind of what I do from a nutrition standpoint, a lot of joint health and overall decrease in inflammation. So I do some of that. And we have some of the passive modalities. A lot of our docs, not me, but a lot of our docs in our practice do dry needling. We have cold laser. We have radial pulse wave, radial pressure wave, shock wave, whatever you want to call it. Some of our docs tape. Some of our docs do a little more MDT, mechanical diagnosis and treatment. Again, you can't do all of the things, but those are some of the different tools that we have available. And it allows you to see a wider range of athletes and a wider range of conditions. But you make a point that it's still multimodal, even if you are not personally doing it.
Yep.
As long as you can help direct it.
Yeah, and that's like you talked about being a traffic cop. Sometimes you're the traffic cop getting them out of your office, but also inside. And just because a practice or a provider does all those things, it doesn't mean every athlete or every patient's getting all those things. It's just that it's like, for instance, like golfer's elbow, right? It's one of those ones where it's a pain in the ass to treat. In our practice, we found, like, by adding laser to what we were already doing with some ART and things, it really helped, and it made that particular condition for us a little easier to treat. And I don't do laser on all our patients, but coming with golfer's elbow or tennis elbow, they're getting laser among
Right.
some of the other stuff. So you can start to get really good at, being kind of a really laser focused, like, okay, this is coming in, this is what they're going to get. And that may look different than the other athlete that walks in 20 minutes later.
Yeah, it's nice that you have those extra tools to apply to your particular patient. And it's weird how you just don't know exactly how each one's going to respond. That, like you mentioned, the golfer's elbow, the medial epicondylopathy is, it can be, I treated a gal with that earlier today. I just started her, treated her just a couple of times, and she's had a bunch of cortisone injections over the years. So, that's going to make it even a
Yeah.
little trickier because, that is not good for those tissues in that medial elbow. So, yeah, we're going to be doing some cold laser on her, and probably some radial pulse wave, in addition to my other stuff. So everyone has their favorite ways to approach it, but some of those stubborn ones can be, you need to have more than just one or two tools.
Yeah. And it becomes kind of like an art putting it all together and figuring
I
out
like
which.
that. It's fun.
Yeah, it is. It is fun. So, all right, we're gonna do a little bit of a not so rapid fire, but we're gonna pick a few kind of regions: foot, ankle, knee, and shoulder, and just some of the insights, thoughts. Like, obviously we could do a whole show on the foot and ankle, a whole show on the knee, but the patient comes in with a foot and ankle injury, we call it like a sprained ankle. What are some of the things that you're evaluating, assessing, and doing in that scenario?
Well, the big thing on the, well, not the big thing. One of the things I stress with let's say it's a classic inversion ankle sprain. Let's just say it's a grade 2 or whatever. You got to go into the whole manipulation and mobilization thing slowly, because if you freak them out, then, because those sprained ankle, they hurt, and you start getting in there and getting aggressive with your palpating and adjusting from day one, you might say, well, they need it. Well, that might be, but if they won't come back to you because they're afraid of you, then that's not particularly helpful. So we, as chiropractors, have a tendency to want to get people back to action, walking or whatever, some kind of movement, like you mentioned earlier about, no, we're not going to put them in a boot for 8 weeks. It's just not how we're going to approach it. We don't want that, all that scarring and degeneration to set in. So we're gonna be more, movement focused. So yeah, now the whole thing with ice at the beginning is controversial, and it depends on who you read, and the research, is clear as mud on that, is whether you do ice or not do ice at the beginning. And on the one hand, they don't want you to do ice sometimes on these injuries because they want the natural inflammatory process to occur. On the other hand, cold plunges and cold showers are all the rage. So
Yeah.
you can get a little confused on it.
Yeah.
But as soon as I can, I want to try and start getting mobility in that foot gently and then more aggressively as I can. Get them walking, weight bearing as soon as we can. We use cold laser on those people a lot to get going, and we'll even do some muscle stim and ice just to start to pump that area. Anything that's stimulated to kind of get the whole thing rolling. Now, a lot of our docs will start dry needling that area very quickly. I like that. I'm always giving people a little nudge in the anti-inflammatory diet direction, because again, as we know, everything heals better when you're not in a pro-inflammatory state, in a kind of a pre-diabetic state. So that's always going to be helpful. And then I just, put them on a care plan. I start treating it. I'm not going to say, hey, see how it goes. I'm going to get them in, and I'm going to get them on a, 2 or 3 times a week schedule, and really start to get movement in there. And then try and, return them back to work or sports or whatever it is that is their particular
Yeah,
case.
and we're gonna tackle that. That's a whole other topic of like return to play guidelines. Brett and I are gonna tackle that particular topic because that's a big
That's
one.
tough.
It's a challenging one, and there's a lot of nuance to it. So that'll be good for us to tackle. Moving up to the knee, I'm gonna frame this one a little bit, going back to that multimodal approach and how when you have different tools in your tool bag, you could have something like a knee issue and you find a foot and ankle or a hip problem, obviously, and you might use one particular modality on the hip and a different one on the knee. So it gives you the ability to maybe do some things for this body part and other things for this, right? Like you may do laser on the knee and ART on the knee, but then you found you need to do rehab with the hip, and you need to do, some uh, manipulation of the foot and ankle, right? Like you might end up using different modalities for different regions for a knee injury, right?
Yeah, the knee is such a transitional area, and you hit the nail on the head on a lot of these. The knee problem can be coming from the foot ankle, or it can be coming down from the hip. Uh, kind of classically, the foot and ankle might be too stiff and needs to be adjusted, and the hip may be functionally too weak and needs to have some rehab. So the moral of the story on the knee is you have to, at least from the lumbar spine down, you've got to check all that stuff, because even knee pain, people will say, since I've been getting my, whatever SI joint adjusted, my knee pain has improved. I've had people say that to me over the years that they didn't even tell me they had a knee problem, but they said, what's weird, doc, is my knee feels better since you've been adjusting my low back. And I know, of course, everything's connected, right? So that could certainly be the case. But my point is that you, and I know you may be thinking, well, Mark, you did a lousy job of taking a history, but you do miss things. I mean, the truth is you miss things. But with your athlete with a knee problem is you've definitely got to look upstream and downstream if you're going to be comprehensive in your approach on the knee. It's not just right where the knee pain is.
Yeah, and it gets tricky for sure, right? Like there's a lot of aspects of that. And you shot a really good video for the MPI Clinical Excellence channel on chondromalacia patella, and
Mhm.
there's a lot to it when it comes to the knee above and below, and you hit it on the head, and that's what I wanted to really kind of frame it, was like you got to get away from just the knee for a lot of these knee issues, and that goes for a lot of body parts, obviously. But
One
we're only
thing
have
I
time.
would make quick note of, as you get better and better at your exams, you can evaluate a knee pretty quickly. If you're new to it, you're a student, let's say, listening to this, you just need to practice it. And then from a joint palpation standpoint, I always say if they have a knee problem, check the knee from a joint palpation standpoint, like we teach at MPI or whatever your approach is, because it doesn't take long, and no one's better off with joint dysfunction than without. So it's quick and easy to take care of that. And but understand you need to look at the big picture on those knees.
Yeah, for sure, and rule out anything potentially crazy, and get those out of
Right,
your office if you need to. So, all
right,
right,
right.
cool. And then shoulder. Lastly, shoulder. What are some of the things that you're looking at when someone comes in with that? And let's just say, for the sake of argument, it's more of an overuse shoulder versus traumatic. That has its whole set of circumstances, but just we see so many overused shoulder injuries that are not traumatic or, surgical. What are you really looking at on that particular patient?
Well, the shoulder's a perfect example when you have to be multimodal, and
Mhm.
I see way more overuse, like you're alluding to. I see way more overuse than trauma of the shoulder. I mean, if you're on a football team or a rugby team, okay, that you're going to see some traumatic shoulder injuries. But if you're in a routine family practice, you're going to see the overuse, and you'll see things on an MRI like AC joint is arthritic, the AC joint is inflamed, it has periosteal reactions. These are all because that AC joint's getting beat up, overstimulated, overused. And why is that happening? Do they have joint dysfunction? A lot of times it's obviously poor scapular stabilization. You have your functional screens for that. The scapular rock test, for example, is one easy one. So shoulder's an easy example of, if the only thing you do for the shoulder is adjust the glenohumeral joint, which tends to be a hypermobile joint, you're
Mhm.
going to be pretty limited on your shoulder success. Now, please don't overlook the CT junction upper thoracic area when you have a shoulder, because they are very connected. I always tell patients, if you have a shoulder problem, you're eventually going to alter the way you use it, and you're eventually going to have a neck and upper back or upper back problem.
Mhm.
Excuse me. And so, get a good soft tissue technique, but boy, you better know how to do scapulothoracic rehab if you're going to treat shoulders. And I tell you, I very rarely do the old school rotator cuff rehab that we
Yeah.
learned originally, because if you're doing the other stuff, adjusting, doing your soft tissue, and you stabilize the scapula, now the rotator cuff has something to anchor to. It's going to start to function a lot better, a lot more closer to normal. So a lot of those people, and this is another example where I'm very thankful for my situation. If I know they need to really get through and do an hour, 2 or 3 times a week of rehab, then I can send them to our physical therapist, and they'll do the rehab, and I'll do my adjustments and soft tissue, and that ends up being a great combination. But the shoulder's a perfect example where you really need to be comprehensive in your approach, and you can't just do one thing and take care of all these shoulders.
Yeah, absolutely. And I'm going to kind of wrap it up with asking some of your wisdom on this. Something that we're seeing a little bit, a lot of the younger docs are coming out and they've got a lot of certification, like they're just like one thing after the other, and they're getting all these different types of trainings and certifications. And sometimes I'm seeing that they're kind of halfway learning one, and they move on to the next thing and halfway learn that, and then the next thing halfway learn that, and they never really get really good at the first thing, right? Like, let's just say manipulation, palpation manipulation, like get really good at that, and then get really good at soft tissue. And you can do this concurrently, so it's not like you have to wait 15 years to get ART certified while you're waiting to get good at manipulation for 15 years. But I just see a lot of people kind of getting halfway good at each modality and never really becoming an expert in it. And so what are some of your advice for those practitioners of how to really be multimodal, but be really damn good at each one, not just kind of half-assing each one?
Yeah, I think you're better off being great at one thing instead of half-assed at two, right? So I saw uh, uh, Mike Leahy from ART get interviewed, and they said, "What would be your advice to a new graduate?" I thought he just gave a great answer, and he said, "Become great at something." So obviously his bias is ART, MPIs is palpate and adjust, and you go FMS, and you go down to MDT. Everybody has their bias. That's fine, but he made a great point that he wants you to become great at something, and then you at least can really do a deep dive on it. So you use the example like a lot of people couple these different treatment modalities together. Let's say they do palpate and adjust with ART, or they do palpate and adjust with DNS or whatever. So let's say it's a shoulder. We just mentioned shoulder. Like maybe they go to Mark King, who does a combination of some soft tissue and DNS and palpate and adjust. But then they also the exact same patient could have gone to an MDT guy who does his evaluation. Is a little different than my evaluation, but also can have a big positive impact on that patient. You say, well, he did that differently than I did, but what he was trying to do was restore more normal function to a dysfunctional area, and then hope that area heals. In the end, we're trying to accomplish the same thing, a little different tools to get there. But I would say to your kind of your point, your question is to be just mediocre at all these things. That just drives me crazy. I would much rather you be great at one thing and then add on to it from there. And I think that's the approach I would prefer as a patient. That's the approach that I would rather be treated by someone who's great at one or two things, and maybe eventually a third thing, and heck, maybe even eventually a fourth thing. But I much prefer somebody who's great at something.
Yeah. And that was good about being old like we are, is when we were in school and coming out, you really just had a couple things that were really out there to do. Now there's a lot of really cool stuff out there, and these younger docs and students are getting exposed to 6 or 7 really cool things that are awesome. But maybe they get a little overwhelmed and don't really become expert at one thing.
I'm quite a bit older than you, and it was really simple when I came out. It was really very much about palpate and adjust, and chiropractic, was MDT was something that the physical therapist did, and soft tissue was, why would you do that if you do a decent adjustment? And DNS rehab didn't even exist. I mean, there was no DNS rehab. They were just starting to do all that stuff. in the Czech Republic, and the nutrition approach. David Seaman wasn't lecturing at that point on nutrition, and some of these other guys that are experts on nutrition. So nutrition back then was, just be a vegetarian and then you're done. And so the list goes on: eat more wheat, and that kind of thing. Whole wheat though, and then that we thought that was the way to go. But it is very difficult coming out now. I think your generation, it was a little more of palpate, adjust, and then ART was really growing at that point. You became an expert at that, and which was great. But each year there's more stuff, and at some point, you start, okay, am I going to do dry needling? Am I going to get a cold laser? Am I going to get radio pressure wave? And the list just keeps going. So at some point, I've had to rein myself in, because I can't stand it if there's something that I don't know and I haven't learned, and it might help me with that one patient that it drives me a little crazy, and it can eventually become counterproductive if you go too far.
Yeah, so I just wanted to kind of ask your opinion on that, because it's out there, and it can be tricky, no doubt about it. And we're not saying don't keep learning, but try to concurrently at least stay expert or get expert at least one thing, and then move to the second thing. So
right, absolutely.
Well, Mark, I really appreciate your time today. This was great. Really appreciate your insights and everything. And so looking forward to seeing you a couple times this year, and I'll be out at the MPI Sports Symposium this year. So if you want to chat about that a little bit.
So March 25th and 26th in Kansas City, right on the Cleveland College campus, we're going to have our annual sports summit. I say annual. Well, we were doing it in Chicago, and then this weird thing called COVID hit, and we actually had to postpone 3 years in a row our sports summit. So we're very frustrated with that, and finally said, okay, finally in 2023, we're going to get back on track. So luckily, we're going to be able to do it in Kansas City, and we're going to do it right on campus. And we're very excited. We do sections, and one section will be palpate and adjust, one section will be rehab, one section will be movement screens, and one section will be soft tissue, and the other section will be nutrition. So David Seaman will come out for that. You get to hit this from multiple directions. This year, the topic is lumbar spine, but we just rotate it. We do foot and ankle, we do shoulder, and so on, and we just keep rotating it through. And you get to see some really good brains, and it's a good mix of a lot of docs from all around the country who are there. And it's a great class, fun to learn for all these different things. I guess the way I would say it is, the tools are things that you'll be able to take back and use on Monday in your clinic.
Yeah, I was there the last live one that, pre-pandemic. So I guess 2019 was there. And because I guess the one in 2020 was like exactly when COVID was hitting us all right at the beginning there, because it's always in that March timeframe. But
we postponed 20, 21, and 22. All three got postponed. We were doing them in Chicago. And Chicago was a little more locked down than some other places. So that made it even a little trickier. So we just couldn't figure out how to make it work. And so we just postponed.
Perfect. Well, I'm excited to go back again this year and speak a little bit on Friday, but I'll be there the whole weekend and attending the classes like I did last time, and looking forward to it.
Great to talk with you, Kevin.
Definitely. Have a good one.
See you, buddy.
That is it for this week's episode, but before you leave, check us out at www.modernchiropracticmarketing.com for all kinds of free resources such as blogs and the podcast episodes. We've got online courses. You can check out the Chiropractic Success Academy there, which is an amazing online coaching system for you at a very affordable monthly rate. There's a free online course on the modernchiropracticmarketing.com website, so check that out. If you're interested in some one-on-one coaching, we can do that as well. We have all kinds of resources for you there, and we would also truly appreciate if you could rate and review this podcast if you're getting valuable information out of it. I can't thank you enough, and we'll see you next week.